Hey, Eisenstein there, my friends, and welcome to the I Give a Damn podcast. Today, my guest is Dr. Jeff Varanelli. Jeff has a specialized interest in dry eye as well as ocular surface disease and can often be found presenting CE on these very topics. Today's discussion will go pretty deep into understanding neurotrophic keratitis, going over possible causes, treatment options, and proper testing. We also discuss some of the frustrations that we face as practitioners with dealing with health insurances, specifically around treating more serious ocular disease. Dr. Varinelli holds many accolades, including being a diplomate of the American Board of Optometry, as well as the American Board Certification of Medical Optometry. He's a fellow of the American Academy of Optometry, as well as a founding member and chair of the Academy's anterior segment section. Jeff is absolutely amazing at speaking and communicating, and I think that serves him so well with teaching other eye doctors how to think about and treat advanced disease states. So I think we'll all get a lot out of this discussion. So without further ado, please subscribe and follow, and let's get going with Dr. Jeff Varanelli. Jeff, thank you so much for being here on the podcast. Huge honor for me just to have you here.
Oh, thank you. I mean, this is great. I appreciate the opportunity. This is fun. I love the setup and, all the intricacies of this. And something as not a camera guy, I wouldn't expect so much goes into this. But this is very impressive, and I certainly appreciate the opportunity to be a part of this.
Yeah, no, and thank you. It also feels a little good to people kind of recognize some of the intricacies that goes into all of this.
Yeah.
I am not officially trained in videography, audio, video stuff. This is something that I've kind of just figured out passionate-wise, like, hey, there's this problem. This is something I want to do. I have to figure it out. And so I imagine maybe that mentality even spreads on to some of your expertise, education. I think it does for all of us.
Yeah, and I would hope it would for all of us. But and I think that's, if we want to consider ourselves lifelong learners, no matter what it is, eye care, optometry, whatever we do, cameras, videos, you name it. I think if we're always staying active and always staying, at the forefront, we're only going to get better.
Exactly. I love that idea. So tell us, just so our listeners get to know who Jeff Varinelli. Varinelli. There we go. Thank you. So tell us just a little bit more your history of optometry and then kind of your career path and how did you get to where you're at? You have so many accolades and just so much knowledge within anterior surface disease, ocular disease, all of that.
Yeah, so went to ICO, graduated in the late 90s, and really coming out of school, I think, we all had that, I just want to get out, I want to start helping my patients.
Sure.
Wasn't really sure the career path that I wanted to go, but I interviewed at a large laser vision correction firm and did that for almost 10 years, and it was great to be a part of, some of these, the newer techniques and technologies and newer lasers and newer surgeries that they were developing, and to work with some truly world-class elite surgeons. And then about 15 years ago, it was time to make a change. And so I went into practice with an ophthalmologist. And, that really kind of opened my eyes as to what else was out there. In the laser vision correction space, you're only seeing a certain subset of patients. So I wasn't seeing a whole lot, but I really recognized that the anterior segment was a really cool part of the eye as well, and I just continued to want to learn more about it. And so I think that's kind of where my path has taken off, is that there are sometimes simple things that we can do to help our patients who are very miserable. And I mean, you now create a patient that's happy, their ocular surface is healthier, and they become very loyal, and they tell their friends. And that just continues to create loyalty within the practice.
It's all very true. I'm curious just because in my own experience when I was in optometry school, and I graduated like 7-8 years ago, and even into my residency, I always found anterior segment either difficult or hard, or I was actually scared of it in some way. Because there's just so many differentials. There's so many things, masqueraders that kind of are going on, and so much more you need to, I think, pathologically understand more about it to be able to really nail down what the exact cause is and figure out the right treatment. And then just in your experience, did you find it difficult? Did you ever find it scary, or?
Yeah, I mean, there's certainly going to be patients that, will encounter that, they're really going to make you scratch your head, and you're really going to think, what happens if I miss this? What's going to happen? Are they going to worsen? Are they going to progress? Is this patient going to lose vision? So I certainly worry about those things. And when I came out of school, we really didn't have a whole lot of dry eye treatment options. It was punctal plugs, artificial tears, cyclosporin was out, or just about to come out.
Yeah.
And that was really it. Sometimes you could hit them with a steroid, but we didn't have the access to what we have now. So I think for any patient, but for me with the anterior segment patients, I mean, just doing everything systematically is really kind of key. And, you have this in your mind, what step process do I want to do? And I think if you follow that and you create some kind of regimen, at least for identifying these patients, the history, the clinical exam, the staining, and obviously there's all sorts of newer technologies out there now for identification. Yeah. And that certainly helps. I don't think we need that. I mean, we have the slit lamp, we have vital dyes, we have lots of things that we can help identify these patients. Mm-hmm. So yeah, I mean, there are certain patients that, scare me and make me scratch my head. And so I think that's going to be true, 25 years out, I still worry about some of those things.
And that makes me feel good. Because, for his... I still have sometimes, so your friend and colleague, Nick Colatrella, he actually runs and owns the clinic where I work at a few days a week. I still hear his voice sometimes in my head because he's been a mentor for me for so long. When I'm seeing a patient, I'm something like, what would, Nick's not here, but what would he think? I try to think
WWND.
What
would Nick do?
Yeah, there we go. We'll have to get a bracelet for him for that. But I think that, so anterior segment disease, I've always personally thought of it as pretty complicated. But I see the power in it because what patient comes through the clinic that you don't see them and look directly at their eye? And there's so many things you can tell about somebody's health from just looking at the surface of their eye. And what's the point of, you can prescribe them glasses, but if the vast majority of their blurred vision, their vision problems are actually because the surface is gone. It's been eroded away.
And that's, the analogy that I use is I'll tell patients it's like looking through a dirty window. And when I say that, I'll normally get the nod from the patient, and they'll say, that's exactly what it's like for me. And so we work on that. But, just kind of having an approach that I think you stay consistent with will just continue to help our patients.
Right now, what are you currently working with? What are some of your biggest passions? So certainly dry eye you mentioned. Right. Is that something that you primarily work on as a specialty in your clinic, or do you just kind of encompass all disease, health, everything?
Yeah, so in clinic, I mean, I'm seeing anything and everything that walks in the door.
All right.
A passion, yes, totally the anterior segment and the ocular surface. And we have a lot of doctors that will refer into our practice. And then you create that loyal patient. You fix them, you made them better. They are going to tell their friends, and I'm going to start seeing their friends. So yes, looking at the ocular surface is really key. I mean, for me, especially with some of the newer things that we're seeing with neurotrophic keratitis, I think that's a very, very underdiagnosed condition. And I think it, kind of puts the onus on us to identify these patients. Now,
you were doing a presentation on that. You've done some continuing education for that for other doctors. Can you just... I know in school we learn neurotrophic keratitis, and if I recall back, the biggest thing I think I remember from school was like, you have an ulcer with rounded edges, right? That was like, take maybe a cotton wisp test, but and that maybe herpetic keratitis is related to it. In school, that's like, okay, I got to remember that for boards. But then when it comes to practice, do you really test for it? Are you really keeping it as a differential? So I know I'm speaking to the choir here, but
yeah, I mean, I would agree with that, and I think part of it is we have these patients that are in our chair. Now they say, I think the statistics are fewer than 65,000 people in the U.S. have neurotrophic keratitis, and I think that is a far underestimation of what we have. I think these patients just aren't getting diagnosed, and that, like I said, that's coming back on us because we're not coming up with enough differentials to say you probably have NK.
Yeah.
And so, yes, corneal sensitivity testing, absolutely, that's the key. That's how we define these patients. And whether it is a cotton wisp or a piece of dental floss, anytime that clinical picture doesn't coordinate and jive with the patient's symptoms, we really have to start thinking that NK is, behind it.
So I have two questions about that, just because I'm like, there's nobody else better to ask than you here. First one, how often do you test for neurotrophic keratitis? And what is the most common cause? I think textbook-wise, from what I've read and know, I would say probably herpetic. But is there anything else that we should be considering or should be watching out for? Maybe doctors aren't thinking of that.
And I think that's key. And I'm going to take the second question first.
Okay.
So leading cause, and you look in the studies, it's herpetic eye disease.
Sure.
So we're going to see those patients. But then there's simple things. So contact lens wear and overwear. The second most leading cause is some kind of neurosurgical intervention for trigeminal like trigeminal neuralgia or an acoustic neuroma, something like that. Yeah. But we have contact lens wearers. We have patients that are on topical medications, long-term topical medications, so our glaucoma patients. The BAK can certainly be a major contributing factor, long-term ocular surface disease. And then you start thinking of some systemic conditions, so diabetes and MS. We all see diabetic patients. Yeah. So I think when you start looking at, I have a diabetic patient, maybe they were contact lens wearers, but they're glaucomatous, so I'm treating them with drops. And then you start looking at their cornea, and there's some staining, but they're really not complaining, but we think that they should be. NK really has to be at the forefront of our thought.
So with diabetes, they're not just not feeling their feet, because I feel like most people kind of think of that.
Right.
There's even that little clip on the old show, House MD, where the guy's shoes are too tight because he's diabetic. He can't feel his feet. We need to be remembering that about the eye. Absolutely. And maybe even telling our patients that, like, hey, this can happen to your eyes as well.
Right. And, kind of getting back to that first question that you said, I remember this ulcer, now there's this defect and, it's kind of oval and you have the borders. So that's the stage 2. And that's when they've already progressed from stage 1. So if you see these patients at stage 1, you identify them, well, then you prevent them hopefully from going to stage 2 and then ultimately to stage 3, where we start to see stromal melts and perforations and obviously things that we want to avoid. So finding and identifying these patients sooner in the process, certainly going to be more beneficial for the patient long term.
Absolutely. So with testing, are you doing sensitivity test on just every patient that comes in for ocular surface disease? Are you testing it on your routine patients with contact lens histories? What's your...
Yeah, so my ocular surface disease patients, yes, I'm testing them. And
are you using the cotton wisp or are you using
So I do both. So I have a Cochet Bonnet.
Perfect.
And, it's kind of fun. It's fun to say. I like saying Cochet Bonnet. Yeah. But it also gives me, the ability to track their corneal sensitivity over time. So if I do introduce some kind of therapy, I know, exactly where their sensitivity has returned to versus is it absent? Is it just modified? Is it limited? Mm-hmm. So absent, normal, or reduced, that's how we can do it with the cotton wisp, which is still a great way to do it. Absolutely. I want doctors testing that corneal sensitivity.
Who can't do that right now?
Yes.
I think, for listeners who maybe haven't seen the Cochet Bonnet, if you're not in the literature or kind of getting into neurotrophic keratitis, they may not know what that is. I only know it because our clinic has one, and I'm teaching my students how to use it. But Cochet Bonnet is kind of correct me if I'm wrong, I like to say it's basically a type of fishing line, or it's like a tensile string, right? But it kind of looks like a pen, and the further it pushes out, the less tension it has, and so patients won't feel it as easier as when it's shorter, because then it's a little bit denser, but it allows us to quantify it, and there's a correlation with age, right? And different quadrants of the
different temperatures, different color iris. I mean, there's all sorts of correlations.
Wow, I haven't even gotten that deep into it. I'm gonna have to.
Yeah, and I don't go that far into it when I look at my patients, thinking that it might be reduced because they have a blue eye or a brown eye. Sure. But I think we have to look at the patient base and who we're going to test. So yeah, all ocular surface disease patients with previous history of ocular surgery. Laser vision correction is a big one. Even cataract surgery we can sometimes see. And believe it or not, if you look at patients that have undergone PRP or some kind of retinal procedures, it can certainly affect the long posterior ciliary nerves. So those patients might be at a little bit of a higher likelihood to develop NK. So, we think, well, it's just all the front of the eye, but I mean, patients can certainly have procedures on the back of the eye and still create these problems.
I think that piece blows my mind. So thank you for telling me that. I'm just learning stuff here. I think one of the bigger things for myself this last year, I had my first patient that she had a brain tumor of some kind, and she had surgery on it. And since then, she always had just horrible she's had dry eyes for like 30 years, but the left eye was way worse. And I saw her and I'm like, you have evidence of previous ulcers on the eye. You have an ulcer here for no reason. She's like in her late 70s. And so then I started tying things together, and sure enough, she had decreased corneal sensitivity, and we started going down that route. But the interesting thing for me is the classification. Like you said, there's three different classifications, I believe, for neurotrophic keratitis. The first one, off the top of your head, can you tell me what the signs are in stage 1?
Yeah. So stage 1, you're going to see some PEK. You'll probably see some epithelial clouding. You might see some corneal neovascularization. But the PEK is probably one of the hallmark symptoms, just that punctate epithelial staining. So it's key 1. I mean, you have to stain these patients. But really pay attention to the epithelium too.
My thing is that how many of our dry eye patients, the patients that are just at least labeled dry eye, right? We kind of hand that out like candy nowadays, whether you do have just have symptoms versus what do you have on the surface. But how many times, I even thinking this to myself, how often am I doing corneal sensitivity testing on a patient who's got PEK? Like, not very often. And so it's almost even a reminder to myself, like, okay, I need to be testing for this on a more regular basis.
Yes. 6 to 8 years ago, I'd have these dry eye patients that just weren't getting any better with cyclosporin, lifitegrast, steroids, plugs, tears, gels, masks, whatever, you name it. And I think back, and those were probably grade 1, stage 1 NK patients.
Wow.
And so now that's why I look at all of my ocular surface disease patients. And, the neurotrophic keratitis is kind of the stain without the pain. So we'd expect patients to be far more symptomatic, but they're not. They might be coming in saying my vision's blurry versus my eyes feel scratchy and gritty and irritated. Right.
I think that is kind of the puzzle sometimes is we'll even have somebody who's younger, right? They don't fit like this older person, older patient who's got dry eye, you kind of expect, but you'll see somebody in their 30s and you're like, wow, you've got terrible dry eye. And they're like, I don't have any problems. I don't feel anything. I feel just fine. I don't need drops. It's like, how do you present that? It's kind of like the glaucoma thing, right? How do you tell somebody, no, we have to watch this. We need to do this extra testing. And they're like, I see fine.
And I don't feel anything. Yeah. Right. So that is one of the challenges. And I think, in those situations, testing corneal sensitivity on them is going to be key, because if it's in one eye and you test their good eye, and they're going to feel that right away. And then when you test the eye that has the reduced corneal sensitivity, that might be the aha moment for them that, well, yeah, maybe there is a problem because I didn't feel anything, or it certainly felt different than what the other eye felt like.
Exactly. So in your practice, are you doing a lot with Oxervate now that Oxervate came out, or what's your treatment plan?
My go-to is going to be Oxervate, and it works well. I mean, I've got patients that moan and complain about, I got to take these drops 6 times a day, every 2 hours. But at the end of the 8 weeks, I mean, these patients are healed up, and I mean, I could write case reports, and I have written case reports on some of these patients because they've done amazingly well. So I certainly will use it for all stages, stage 1, stage 2, and stage 3. If it gets to that point, we try to avoid the patients getting to that point by starting them sooner on the therapy. But I've had great luck and success with Oxervate. Dompe has really put out a product that has done great.
And I think for myself, again, I wrote my first prescription for Oxervate way earlier in the beginning of 2022, and I was actually surprised at how, filling out the forms, there's a few steps, right? For doctors who are listening and haven't done it themselves, there are some steps to go through it. But I think, the Dompe, who's been kind of running it, is doing a good job for both patient education as well as helping us doctors kind of get through it, except for the approval process.
And I think that creates a little bit more of a challenge. So there is some forms that you need to fill out, and everything is really done through kind of an intermediary that then connects you as the doctor, the patient, and then the specialty pharmacy for the medication. So it's only 2 pages. The patient fills out a lot of it, and we just basically have to fill out, does the patient have reduced corneal sensitivity? So you absolutely have to test and document that they do. How many times a day you want them to use it, but it's always, 6 times a day every 2 hours. And what eye is it in? Is it unilateral or bilateral? And you fax it off, and there's a little delay and lag just as they kind of work through some of the insurances and make sure the I's are dotted and the T's are crossed. Yeah. But I mean, it works, and it works great for the patient, and there's a little bit of a legwork on our part, but we're in it for the patients.
Other than prescribe, so in that case, I'm just curious for my own knowledge and just for everybody else, when a patient is being prescribed Oxervate, do you also keep them on their Restasis, their Xiidra? Do you keep them on steroids, any other medications?
So yeah, if they are a glaucoma patient or they are a dry eye patient, sure, I will certainly keep them on their concurrent therapy. Mm-hmm. But we don't use the drops within 15 minutes of each other. We don't want, obviously, wash the effect of one out with the other. But yeah, you'll certainly want to keep them on what they're doing, especially if you're also managing another chronic condition that they have.
So obviously we're having huge kind of growth in this world of just awareness of neurotrophic keratitis. Now we have this amazing treatment as well. Right now, what has been, obviously, do you have any frustrations kind of with it? It's really exciting, but is there anything that you're just having either difficulty yourself you've seen in the clinic, or just issues that you see kind of going on in our profession around neurotrophic keratitis or ocular surface disease?
Yeah, I mean, there's always going to be the issue with insurance and coverage. And, I'll talk to patients that insurances are companies, right? So they look at their bottom lines too. But, the frustration is I have a product, a drop, a treatment that can work great for a patient, and I sometimes have to go through significant hurdles. And not just neurotrophic keratitis, I mean, for allergies and glaucoma and dry eyes. And I think that's probably the biggest frustration, one of the biggest frustrations that I have in treating these patients. We could do the greatest clinical workup. We could identify these patients, and the patient is rearing to go, yes, make me better. And then we get something faxed back from the pharmacy saying, sorry, it's not covered, or you need a prior authorization, or they need to fail on this medication first. Or, I mean, the list just goes on and on and on. Right. So not only does that frustrate us as the provider, that we already determined what the patient has and what they would likely be a benefit from the most, but it's frustrating for the patient too, because now they're kind of dealing with maybe a delay in starting their treatment. They're, dealing with their insurance company, maybe contacting them or getting letters saying your PA has been denied, and so they're calling the office. So there's legwork everywhere. Right. And I think, and I don't know what the answer is to fix that, but I think education and just continuing to write these scripts is what's going to hopefully allow more of these drugs and drops to get on different formulas and hopefully get better coverage. Yeah,
I know. I'm constantly frustrated by insurance. I think every doctor is. Everybody who's listening is just like, they probably can't think of a time where this, like, yes, this. I even one time, I'll admit this, I swore in front of a patient, which is something I've just never done. But it was under my breath, and I was treating a patient for, I forget, it was something I was prescribing cephalosporin for. I was prescribing 500 milligrams of Keflex or whatever. And at least with our program, it was able to tell me what the patient's price was going to be. And it came up as saying $1,000 for like a 1 week course, like 10-day course of cephalosporin. And I just, under my breath, I dropped the F-bomb, and the patient looked at me and I said, I'm really sorry. And then I explained myself. And if anything, we had a better bond over it because I told them, like, there is no reason it should be that expensive. And so I switched him to a generic, right? And then it was like $10. Right. But I'm just curious of your experience. Do you have is there any stories or time you can tell where maybe a patient was in jeopardy or became or did become a problem because the insurance got in the way?
Yeah, it's funny you say that. I had a patient years ago, and it was a teenage girl, and she came in with the complaint mostly of blurred vision. But, just upon further questioning, I had asked about headaches, and I said, headaches as well? And she said, yeah, actually, now that you mention it. And so you start putting two and two together. And so she has some blurred vision issues. She has some headaches. And then I dilate her, and I look at her nerve, and her nerve is elevated. Mm-hmm. So I think I did what most optometrists would do, is I ordered an MRI. And I sent her for the MRI, I give her the script, and I told her I'll call you when I get the results. And we get a call from the insurance company saying, nope, sorry, we're not going to cover it. And so first, and I had to talk to a nurse, the nurse manager, and I said, this is why I need to have it. This patient, this could be something sight-threatening, it could be something life-threatening. She needs it. Well, sorry, it doesn't meet the protocol. You're going to have to talk to a physician provider to get this approved. And so it just kept on going up the chain. And I finally said to the doctor, I said, if this is your daughter and she loses her vision or worse because you didn't approve this, would you be able to live with that? And he said, good point. And thankfully, everything worked out. We got it covered and everything was fine with her. We were able to address her needs. But, that's a little bit more of a deeper issue than, just the PAs with some of the topical drops that we want to use. But it's everywhere. It's going to be for, the patient that sits in our chair that we want to order some additional testing or order a drop. And, we're going to get some kickback. It's going to create a little bit more of a challenge.
I don't always even on the simplest thing, it blows my mind how insurance really does dictate and control a lot of how we practice. If I think one of the classic examples is if you have a patient where you suspect, that you catch multiple things in the back of their eye. You see, okay, they have some sort of a choroidal nevus. Let's take a fundus photo. Oh, but they also have, let's say, a swollen optic nerve. I want to do an OCT or something like that. Suddenly, you can't bill both. Or you're like, something's wrong with their vision. It's not 20/20. I need some explanation. Maybe there's something subtle with their macula. So you go to a macular OCT, but it comes back normal. And then all of a sudden the insurance says, oh, we're not going to cover that because it's exploratory or something like that. Well, what does the ER do when somebody has a chronic bad headache and they order an MRI and it comes back normal? Are they still getting reimbursed for that? Whose money's on the line for that? Is it so there's a lot of it feels like they have so much control, and it's frustrating.
Right. And that's kind of been one of the things that I've seen for 25 years of practicing, is that's always been there. And I think we're noticing it a little bit more now, just because there's newer drops and newer things that are out there, and insurance companies do look at the bottom line. So I get that, and great points.
I think one of the things that's not just in optometry, this is across the board for all medicine, but it's frustrating. And even as a consumer, right? I pay for health insurance, and it's frustrating to hear that some like big insurance companies, they're like, oh yeah, it's our bottom line. It's like, really? Your CEO made $300 million last year. I have a hard time believing that you're not reaching that bottom line.
Sure.
So I don't know.
I
don't know what the answer is.
And I don't either, but I'm hopeful things will change and can change this, just as we continue to write these scripts and continue just to push for our patients. I mean, I think that's what we have to do is just continue to do what's in their best interest.
I completely agree with you with all of these points. I think just kind of a different topic. I want to kind of switch things around because I'm curious. In the world of dry eye, over the last several years, even since I graduated, I feel like there has been more and more attention with dry eye, more classes on it, more CE, specialty workshops. Certainly new medications are coming out, so I think maybe our awareness, our ability to diagnose it is becoming better. Are there any frustrations that you have with it, like with our own profession and how we're managing, diagnosing dry eye, maybe our understanding of dry eye?
Well, I think it's certainly evolved.
Yeah.
And then you look at some of these workshops, like the dry eye workshops that they've come up with, and just the collaboration, the do's and the do's twos, and the tear film monocular. I mean, that whole thing has really taken dry eye to the next level. And I think we as optometrists can look at that and say, this is something that I can see and treat and make the patient feel better. So I think, maybe some of us are a little bit more drawn to it because we can see the results of our treatments.
Right.
From a retinal standpoint, we can certainly all diagnose what goes on back there, but to a certain degree, we can't treat anything, right? We have to send them out to a subspecialist to address some things that might need to be addressed from a surgical or a procedural standpoint. But the ocular surface is completely different. So I think that's probably why we're seeing more attention maybe paid to it. It's something that we could see, it's something we could do, it's something we can treat. I think now we have a better understanding of it. And I think as our understanding of it just continues to improve, we're going to see differences in therapies and treatments coming out.
I know it's kind of, every time you're saying like dry eye treatment, I'm always thinking like, it's true, like we can't really cure dry eye, right? It's very rare that somebody's fully cured of it, because how often, you put someone on the medication, you help their symptoms, but are you able to wean them off of it? It kind of goes back to the like what really caused the dry eye. Have you had cases where you've been able to rehabilitate somebody out of dry eye?
Typically not. And that's a conversation that I'll always have with a patient, that I am not going to cure your dry eye. I can treat it. I can manage it. I have two goals. I want to make you feel better. I want to make you in the front surface healthy. So I want to make you feeling better. I want to keep you healthy. Those are my goals. But generally, I am going to have to do that with some kind of therapy. And I'll almost use the analogy of high blood pressure. Okay, you go to your doctor, you have high blood pressure. He puts you on a pill, and your blood pressure is normal. If you stop taking your pill, your blood pressure is going to go back up. So I kind of use that analogy with patients that, yep, you're going to start to feel better and see better, and I'm going to look at you underneath the slit lamp, and I'm going to think you look better. But if I take you off or you stop using the drops, and I mean, your patients will tell you the same thing. Well, I felt pretty good, so I stopped using it. Or I went on vacation for a week and I stopped using it, and I knew that I needed it. And I think if patients have that mindset that this is a chronic condition and we need to treat you, and you need to think of it as a chronic condition, then yeah, I'm never going to cure it, but I can certainly manage it. We can certainly treat it. But it's also on the patient to be proactive in their care as well.
Yeah, and I'm just curious, being in this world, there's so many treatments about dry eye, but I know you have some passion with amniotic membranes,
Yes.
right? And you've used those for quite some time. I think, in fact, that was probably the first CE I ever heard from you. And I was, again, a student who, I was probably the first, maybe one of the only students at my school at the time who got to use an amniotic on a patient. And then, of course, I ended up where I worked with Nick Colatrella. He kind of kept on teaching me more and more about it. But just tell me more about kind of how you guys are you using amniotics a lot on patients specifically for dry eye? What are you using those for?
Yeah, anytime that we have something going on the surface. So dry eye and recurrent corneal erosions are probably the two biggest times that I will use them. But I've certainly used them for filamentary keratitis. I had a Salzman's nodular degeneration patient that I used it just on Monday, just this a couple days ago. But anytime you have a level of ocular surface inflammation that you just kind of really want to rehabilitate that cornea, it's almost like induction therapy. So we're still going to likely do something afterwards. So whether it be a cyclosporin or a lifitegrast, or varenicline, the nasal spray, we need to get them to a point where their cornea is going to be a little bit healthier, and then now we just kind of continue the therapy. Mm-hmm. So even chemical burns, we could do it for chemical burns, but dry eye and recurrent erosions are probably my top two where I'm using it in practice, and they do a great job. I'll talk to the patients that I don't know if the effect of this is going to be achieved on the first one, or maybe I have to do multiple, or maybe even with your other concurrent therapy, I might need to repeat it in 6 months or 6 years. I don't know. But using them for the past 8 or 10 years, maybe even a little bit longer, some of the results that I've seen, some of the letters that I've gotten back from patients, some of the gifts that I've gotten from patients just for me doing my job.
Isn't that amazing?
It is. And, I look at it and I'm humbled by it because it's such a simple therapy and it's an easy thing to do. And I could certainly improve these patients' quality of life doing something like this.
Right. And I know it's something that I've used. I'm just curious. There's a couple different things, like questions I would love to ask you. First, some doctors have different opinions on this, but do you have a preference over cryopreserved, dehydrated, experience either way?
I have a lot of experience with both. And it really depends upon the patient. Sometimes anatomy plays a little bit of a role. The cryopreserved one, has a little bit of a larger ring, and that might be a little bit more uncomfortable for them. If some patients can't tolerate contact lenses, well, then maybe the dehydrated one might not be appropriate for them. But I've used them all. I've had great success with them both. I think, in clinical experience, what I have seen as far as results for all the conditions that we mentioned, I've used cryopreserved and all the different dehydrated ones on these conditions, and I've seen great results with both.
And so funny enough, after learning more hands-on over the last few years myself, I've done some educational videos on how to put them in, take them out, and I hope to do some more. But because I think they are incredibly easy. They're something that I think every optometrist going through their schooling should be able to easily do, probably even in their second or third year of schooling. It's like, why shouldn't you be able to know how to do this? If you can put in a punctal plug, you should be able to know how to put in an amniotic membrane. But I know right now there's still not many doctors offering it or doing it, at least statistically. I think a few years ago it was like less than 5%, right?
Right.
So why do you think there's such a holdup?
I think, it's the element of the unknown. So it's something new. Mm-hmm. Many of us, when we were in optometry school, we weren't taught on how to put a speculum in. And so I think that's maybe one of the blocks is it is something new that's out there. But, I did a workshop yesterday on amniotic membranes, and we had close to 20 docs in it, and we're doing another one tomorrow. So there still is a desire for these doctors to learn. And we've done, Nick, who you've mentioned, we've done probably close to 30 of these around the country at different events. We've done at Academy, I think 8 years running now, and some other state associations as well. And it just, I think more and more people are starting to see the benefit of it, but that percentage of doctors that are using them is certainly increasing. Years ago, we gave a lecture at a state association meeting, and we asked a question, how many of you have put one in? And no hands went up. We had crickets. How many of you have seen one? No hands went up. Crickets. The last question we asked was, how many of you have heard of an amniotic membrane? No hands went up. Crickets. And this was probably maybe 9 or 10 years ago. And it was something that, was kind of an eye-opener for us, that we need to do a better job educating our colleagues on this. And so we've also done some of these at schools as well. So the colleges of optometry, we're doing this and bringing it to the students, as you mentioned, a little bit sooner. So it's not something that they have to now try to figure out and learn on their own once they get out into practice.
I think that's a major thing, the whole learning, education. Clearly, you're giving back. I'm curious, just because you've been doing this a long time. What's your motivation? Like, do you really just love seeing new technology? Is it that you just love what our profession was capable of doing? Like,
Yeah, and I think it's kind of a combination of those. So yes, newer technology, newer gadgets. I'm looking at all your gadgets here, and I'm like, this stuff is really cool. The profession as a whole, that we can do something like this. But, the big part is when I make that patient better. And whether or not I show it to the patient, but inside it's like, I nailed that. And this patient is doing great. And so there's like this little sense of pride that I'll have that, we can do this and we can make this patient see better and feel better. And we can address their cornea, whatever the case may be. So I think a combination of all of those things, is certainly motivating. And so I guess selfishly, yeah, it's the pride, but it's I've made you better and you feel better and you're happy, and that's worth a lot too.
And I think that's great. And I can feel that just coming from you, getting to talk with you a bit. You come off as one of those people that you love your work. And if you hit something and get it done well, even if no one else sees it or appreciates it, you feel good going home because you did a good job, right?
Yeah, I'd agree with that 100%. It's a great way to say that.
And I know that's something that I think I've even done well. It's like, even if this patient, if even just a routine exam, something as simple as doing a refraction, and, they take their prescription, go elsewhere, choose not to update their glasses, still I'm just like, I did a good job.
Right.
I'm
want
happy
that
with
pat
that.
on the back, right? I think, we're all kind of wired that way to want to see the results of, our years of learning that, yeah, I knew it. I did it. I made them better.
And I respect that in you. So thank you for sharing
you.
that. Overall, I was going to say, this has been a fantastic conversation. I'm learning a lot from you just sitting here.
Thank you.
There's something that I agree. I share that passion of I love the learning part of it. If I am reading a study or some published research, I can get lost in it and just even appreciate, it blows my mind, physiology-wise, humans are so complex. It's beautiful. There's a sense of beauty of just how complex the eyeballs are in itself. And I just love it. And so I can sense that in your passion, and it's something I think most optometrists probably do. If they're not too burnt out yet. And
I think that just all goes back to, I think we have to continue to maintain our learning. We just can't sit and just stay stagnant. So our profession, yes, it requires us to take these classes and attend some of these great lectures here at Academy. But I think, just kind of taking that extra step and, questioning yourself and how you're doing things, and you have this patient that doesn't make sense, and do you reach out to a colleague and ask them? And I think it just starts this whole different thought process. And, you have journal clubs, and you have, there's so many ways that we can, even if you just take, one of the industry journals that's out there and you just start thumbing through, it's like, well, I never thought to do it this way, or treat a patient with this, or whatever the case may be. And it just creates, I don't know, that passion that you're talking about. I just haven't stopped. And I guess until I don't stop, I guess I'm just going to keep on doing what I'm doing.
That's awesome. Well, again, Jeff, thank you so much. You're an inspiration, certainly for me, in hearing about this. I look forward to hopefully seeing more information about neurotrophic keratitis and hearing just future CE lectures. Maybe I'll have to jump in and head on over to Europe and see you guys
certainly
present then.
Yeah, this was great. So I certainly appreciate the opportunity. This was fun. I'm glad we got to talk about some of the things that we both enjoy and both like. And I again appreciate you asking me to be a part of this.
No, thank you.